All right, good morning, everyone. We're going to get started. Thank you all for joining us this morning. My name is Dana Slowinski, and I am co-owner of Family Recovery Centers. And we're very excited to be partnering with Courage to Connect this morning on autism evaluation. Really quickly, I'm going to give you just a quick overview of Family Recovery Centers for those of you that are not as familiar with us. We are an intensive evening outpatient program for adolescents and their parents. We have locations in Lake Bluff, Hoffman Estates, St. Charles, and we're going to be opening our fourth location in the Yorkville area coming fall, winter. And two program components I'd like to highlight are parent involvement and our 24/7 on call. So parents are involved 2 of the 4 evenings right along with their child. So they're learning skills right along with their child, and then we're also doing their own work. So we're really focusing on the whole family system and the family dynamics. And then we also have a 24/7 on call. So our staff is available to both the kids and the parents 24/7 to help with skills coaching in their real lives, not just when they're in treatment with us. We work with a wide range of adolescents struggling with maladaptive behaviors, self-injury, substance use, depression, anxiety, and ADHD, a whole gamut. So that is us in a very quick nutshell, because I do want to get on to this presentation. So if you have questions, please feel free to ask myself or Ryan. Both of our emails will be on the PowerPoint, and you'll receive an email. Also to note, you will receive the PowerPoint in an email following this presentation, and as well as instructions on how to obtain your CEUs. So without further ado, I will turn it over to Kimberly Burka with Courage to Connect.
Good morning, thank you. So I'm Kimberly. I am a nationally certified school psychologist. I have worked with Courage to Connect for the last like 2.5 years or so. Prior to that, prior to working in the private practice, I was in the public schools for 12 years working as a school psychologist. And I am presenting today with Dr. Jamie Long. And Dr. Long, you're muted.
Sorry about that. So I'm Dr. Jamie Long. I work at Courage to Connect as well. I've been there for about a year. So before that, I worked in the public schools for 4 years. And then after that, I worked in a private therapeutic day school for 2 years. So.
All right, thank you. So our learning objectives today are to increase your knowledge of the characteristics of autism spectrum disorder among different age levels. And we're also going to be talking about the differences in gender as well, help you to develop an understanding of when an evaluation may be needed and understand the evaluation process and benefits. So the definition of autism is it's a group of disorders that the onset is typically during the preschool years, and it's characterized by difficulties with social communication and social interaction, as well as repetitive and restrictive interests and behaviors. So it uses a spectrum term. So that means that there are variations. So there's individuals who are on the spectrum that are very high functioning and very verbal, and then individuals who might be lower functioning, and some individuals with ASD are completely nonverbal. Now, there used to be some other categories like Asperger's syndrome, childhood disintegrative disorder, and those are no longer incorporated into the DSM. Everything now falls under the umbrella of autism spectrum disorder. The prevalence of autism, the recent estimates show that 1 in 68 children in the US is affected by autism. However, there is more recent research that is showing that we may not be catching all of those girls who have autism spectrum disorder. So those numbers might be an underestimation of what the true prevalence of autism is currently. So the characteristics of autism can become apparent as early as infancy. So infants and young children with ASD characteristics might be more focused on certain objects. They might become very fixated on things. They could have inconsistent eye contact and may not look in the direction of their caregivers. So if there's like a loud noise or their name is said, even when they're younger, typically babies will, avert their eyes. And infants with ASD might not do that. They might not babble with their parents. And another hallmark of ASD is they could have language. So they might begin talking around, like 18 months, and then they lose that language that they once had. And then as children get older, if they have characteristics of ASD, they might not play or engage with other children, or they might prefer to play alone. So developmentally, that parallel play is typical earlier on in development. So they might play with similar things, like children might be playing with blocks, but next to each other instead of with each other. But individuals with ASD might not make that jump then from parallel play to that social interactive play. So they might continue to have that parallel play even after their peers are beginning to interact more reciprocally with each other. Another characteristic is also that they might not be able to express their feelings and emotions and understand the feelings and emotions of other people, as well as their more neurotypical peers. Some language characteristics for individuals with ASD is some might not have any language, so they might be considered nonverbal. And then there are others that are highly verbal. Again, it's that spectrum. So there is a lot of variation in individuals with ASD. And then in individuals who are verbal, there can be difficulties with fluency, volume. They could also have different delays in areas of language like expressive language, receptive language, and those pragmatic social skills. There can also be a flat or more robotic tone, so not a lot of variation in the intonation of language. Repeating phrases or giving unrelated answers is also a language characteristics, and then not being able to pick up on some of those social cues. So, not using that eye contact as much as their typical peers, not understanding, some of those, like arms crossed, or, if somebody looks like they're upset, they might not recognize that as easily. They can also have some restricted or narrow interest of behaviors. So they might be very into a certain topic like Star Wars or horses or something like that. And so that is what they like to talk about. And they will always try to kind of divert the conversation back to that, or they might have difficulty talking about anything else other than those topics that they're very interested in. Some repetitive behaviors are also a characteristic of ASD. So hand flapping and rocking back and forth are some of those more, kind of typical or, behaviors that you kind of associate with ASD. But there can also be other repetitive movements like twirling around, flexing your hands, other repetitive motor movements, twirling hair, things like that. And then they might have a preoccupation with parts of objects or an intense interest in those different topics. So, taking things apart, various sensory aspects like lights or sounds, or how something feels, those could be repetitive behaviors as well. And then there can also be restrictive behaviors. So, sensory differences are very common in individuals with ASD. They might react more to loud noises, and they might have, like if there's a large group or a lot of visual stimulation, a lot of lights, that might be overwhelming to them. They can also have trouble coping with different textures of food, the way that clothing feels on their body. Even just physically being touched can be difficult for them as well. They can also have an inflexibility to different routines. So if their routine is changed, they might have a very big reaction to that. They could become upset if, you know, an object is moved in their room because they like their environment to be very much the same and predictable. So that's something, you know, that can be very upsetting to them. So children with autism have kind of a different understanding of the world. So their life in general can feel very unpredictable and confusing. So they like to have that, you know, sameness in routine and environment. And that can be very upsetting if it's changed for them. So some early indicators are not having any of that spoken language. So that babbling or, you know, pointing at different things that are pretty typical around a year old. And then some of those other language milestones, single words by 16 months, two-word phrases by age 2, not responding when they hear their name. And then also, like I had mentioned previously, that loss of language or loss in social skills that they might have gained at some point. Poor eye contact, excessively lining up toys or objects, and then also not smiling or having that social responsiveness in with caregivers or peers. So some later indicators might be difficulty with making friends with peers. So something that can be common in children with ASD is they might not be able to make those social connections with peers. They might be more comfortable interacting with adults because adults sometimes can be more tolerable about listening to their specific areas of interest. They might also have trouble starting or keeping conversations going with others. And they can also have an impairment in that imaginative or social play. Repetitive or unusual use of language and an abnormally intense or focused areas of interest are also later indicators. And then that inflexible adherence to different routines or rituals and preoccupation with different objects or subjects is also a later indicator as well. So next up,
Thanks, Kim. So yeah, we kind of hit on this before, but autism used to be thought to be 4 more times common in boys, and girls were really only getting identified if they really stood out. So like if they had intellectual disability, they were more likely to get identified with autism. Also, if they were demonstrating like a lot of behaviors, they were more likely to get identified. So a lot of girls are going under the radar. They're more likely to be diagnosed later in life. And I have a fabulous chart, which I am going to share. And I can't take credit for it. This is Dr. Donna Henderson made this chart. She does a lot of work with autism. So this chart is really helpful because it also hits on some of the more subtle characteristics of autism, which can be present in both boys and girls. So this on the left are the autism criteria from the DSM. And here it breaks it down into what those can actually look like. And so the first one, the social emotional reciprocity. So people can think like typically that like no empathy, completely disengaged, but it can be more subtle than that. So it can just be things like a child is failing to respond to their name, they're struggling with greetings, they're struggling starting conversation, they're struggling with engaging in a variety of topics. So like Kim talked about those kind of restricted topics being really focused on one thing. They can struggle with taking turns, responding to praise, picking up on those little social breadcrumbs. So something like you might share an interest with them and kind of drop something, see if they'll pick up on it.
Dr. Long froze. I'm hoping she comes back. Just gonna give it a minute. She is the one sharing the presentation, so we might just have to troubleshoot this really quick. Let's see if she's able to come back in.
I will also just say in the interim, we do have a question if we'll get a copy of this chart. And yes, this will be as part of the PowerPoint for that you will be emailed.
Thank you.
I'm wondering if I could just jump in really fast while we're waiting for Dr. Long to give a little information about Courage to Connect. We are an outpatient mental health center, and we are over 5 locations. We have 2 in Glenview, 1 in Lake Bluff, 1 in Glencoe, and also in Wilmette. We provide psychological testing, which Kimberly and Dr. Long provide for us, as well as therapy and psychiatric services. So we welcome any referrals that folks have as well. Oh, and it looks like she's back. Here she is.
Sorry.
Thank you,
Hold on. Yes, sorry about that. Let me just reshare presentation. All right, sorry about that, folks. So girls typically trying to fit in more than boys, trying to kind of repress those traits that make them different because like social functioning is just generally more important to girls typically. So girls can be more engaged, chattier than boys. They kind of mediate social behavior through their prefrontal lobe. So they're considering things, they're working through things, they're trying to organize these interactions and make sense of this. And so I'll get at this a little bit more, but when you're doing autism assessment, especially with girls, it's super important not to just look at, do they make eye contact with you? Do they have friends? But get at their internal experience. Like, are they do they feel like they have to suppress their behaviors? Are they mimicking other people's eye contact? So really not just how they present on the surface, it's important to get under the surface and take a look at that. Then the next criteria, problems developing or maintaining relationships. And people typically think the child doesn't have friends and doesn't want friends. But what it actually means, and Kim hit on some of this as well, trouble engaging in reciprocal play, difficulty understanding relationships, difficulty making and keeping friends. So I will hear sometimes an assessment how people had friends when they were younger, they would have play dates, but then it just tends to fizzle out and those relationships don't maintain over time. There can also be some struggle to have friendships at their developmental level. So things like fitting into groups, having a best friend. There can also be trouble with social motivation and social energy. So that desire to have friends and that desire to feel like pumped up, you're going out with your friends and excited about it. And then in addition, there can be some difficulties managing conflict. Children with autism can become very upset when things don't go their way and like make it black and white and say there was a conflict with this person's my enemy, that sort of thing. But for girls and women, the differences in play are a little bit subtler. They engage in more pretend play, and they might be able to get through until middle school. And then when the social pressures become more, that's when the difficulties might come out. And so, like I was saying, it might look like they're blending in on the playground, but internally they're having that struggle. And girls can be more likely to play with younger children than just be a loner without any friends. And then it is interesting when they have done brain scans, girls with autism's brains tend to look more like a typical boy. So they're functioning more at that level, which is an interesting finding. In regards to nonverbal communication, people perceive like expecting just no eye contact, a totally flat affect, but it can be more complicated than that. So children with autism can have trouble using eye contact to manage interaction. So maybe instead of no eye contact, it could be really intense eye contact. It could be trouble with body posture. So I've seen kids that really strict and rigid and have like their hands in front of them the whole time when they're talking to me. They can also have difficulty with personal space, also with nonverbal communication, being able to perceive others' communication, and then being able to express themselves nonverbally, which is one of the things we look for in autism evaluation. So things like gestures can be really important. And then Kim hit on some of the volume, those types of voice issues. And then having a flat affect can be indicate difficulties in the nonverbal. It could also be an unusual affect. So it could be things like laughing inappropriately. But in regards to girls, they tend to have better nonverbals than boys. So they're better able to do the eye contact, to do the body language, to change the tone of their voice. So that's what I was getting at. Like you have to ask like about the girls' experience with eye contact. Like, did they have to train themselves to be able to make eye contact, but their natural inclination is to look away? I see a lot of girls and women who say, you know, they can maintain eye contact, but it makes them very uncomfortable, or they do things like not exactly looking the person in the eye, like maybe focusing on the person's head or something like that. So they're not exactly looking the person in the eye. Okay, so these are the other three. Oh, oops, it didn't scroll down. Hold on a second. There we go. Okay, so these are the more repetitive and restricted criteria that Kim went over. So there are 4 of these, and you, in order to get the autism diagnosis, you a child needs to have all 3 of what I talked about on the previous page, and then they need to have at least 2 of 4 of these criteria on this page. So the first one, repetitive or unusual speech, movements, or use of objects. So a lot of times people think of like hand flapping or repeating phrases over and over again. And so, but it can also hit on different things. It can hit up on lining or organizing toys, some kind of odd phrases, scripted language. So that could be repeating phrases that other people have used, or like repeating language from movies or TV shows, especially. It could be kind of an odd way of speaking, like reversing pronouns can happen. Sometimes it can be humming noises or making other unusual noises. Sometimes a walk where it looks like they're walking more on their toes. And then getting at those restricted kind of interests, it could be watching the same movie over and over again, reading the same book over and over again. And it could also be skin, repetitive picking, which could be like skin picking. So for girls, it's well established they have fewer and subtler repetitive behaviors. So you might see them do things like pace, walk around the perimeter, twirling is one I see a lot. And you might also see them reading the same book over and over again, or again, like watching those TV shows. So the next one, inflexibility. People typically think children are just getting really hung up on routines or having rituals that seem very intense, but it can be more subtle than that. It can be having difficulty transitioning between activities. This can happen both in the classroom and at home as well. It could be difficulty with change, and it could also be getting fixated on things, and having that perfectionism can also be a sign. And then in addition, black and white thinking, having an overly strong moral compass. So really that strong sense of right and wrong and getting really hung up. It could be rigid following of rules. And then it could also be struggles to understand humor or taking things very literally. And I have found, working with autistic children, they are often very funny. They might have trouble understanding humor, but I've definitely found so many who have their own sense of humor, and you can really engage with that if you really work to kind of understand them, is what I have found. So girls are less likely to have the behavioral problems. So they might be experiencing internally like a lot of anxiety over change, a lot of anxiety over transitions, but they might not be expressing that through their behavior. Like a boy might be having like a meltdown over a transition, while a girl may be just experiencing more of that internal angst. So girls are more likely to be perfectionist, be rigid in following the rules, and have that anxiety. So the next one, talking about interest. So sometimes people view it as just having like really odd interests, something like getting fixated on airport codes, or just things, train schedules, just kind of odd things that you wouldn't expect a child to be interested in. So the interest can be atypical, like something that's unusual, or it can be a very strong interest, like at a very strong level. So it can be more personalized to the person. It's just very strong. It can also be attachment to certain objects, like we see having to carry around stuffed animals, having to carry around a pillow, having to carry around a blanket, that sort of thing. So it's also established that girls have fewer and less obvious restricted interests. And so this is interesting. Girls tend to have like more typically female interests, but at an intense level. So it can be things like loving animals, loving reading, even things like getting really focused on social justice, movie stars. And so it doesn't stand out quite as much because that is kind of what we would be expecting a girl to fix on. So it might not stand out like maybe this is a sign of autism, because that's kind of what girls are expected to focus on. And then women, they can be grown-up women, they can be really fixated on one of their children as one of their intense interests. So in terms of the sensory piece, usually it's thought really unusual sensory interest. So things like staring, looking at a fan, that sort of thing. But the sensory sensitivities can be more subtle than that. It can involve various things like smell, sound, feel, taste, sight. Also, an unusually high tolerance to pain can be an indicator. And then that might explain some hygiene problems children have, because if they're going to be like overly sensitive to heat or touch, they might have a difficulty bathing or brushing their teeth. That might be very sensitive for them, almost to the point where it feels painful. And then there's really no clear difference in women in regards to the sensory difficulties. Like they still have sensory difficulties, but again, they might not have a meltdown if they're overwhelmed in the sensory capacity. They are just internalizing that and feeling a lot of anxiety and feeling a lot of distress, which they might not express. So that's why it's really important to get to their experiences. All right. Okay, so I think I hit on some of this in the previous grid, but I'll just cover some of this. Yeah, trying to mask their differences is really interesting. And I have heard this in like teenage girls and also women who are more young adults. Like I've had women come in who have great eye contact, but then you talk with them about their experiences of it, and they're sitting like studying like how to do greetings, how to interact with people, how to practice eye contact. Like it only comes to them after some practice. So that just because at the moment of the evaluation they have good eye contact, that doesn't indicate that they would not qualify, because they have been studying how to do that. It's also interesting because girls might watch TV shows over and over again, trying to figure out the nuances of social interactions. They may have kind of scripts to deal with social situations. So kind of like standard canned phrases they use in response to things. And then again, it can be really hard to sort out what girls and women are feeling internally.
So next, we're going to talk about when to seek an evaluation. So if you're a clinician or a parent, if you're noticing any of these early or later indicators of ASD, you can talk with your child's pediatrician, or if it's, an older adolescent or adult, talking with their doctor, family doctor, or even their therapist. And seeing if they recommend an evaluation, but you can also reach out to us at Courage to Connect as well to begin the evaluation process. So the steps that we take in order to conduct an evaluation, the first is an intake meeting. So we collect background information and ask a lot of questions, get a lot of that information about the development and socially how the individual is doing, medically what's going on, and try to get as much information as we can. And that helps us then to inform what evaluations and assessments we're going to do as part of the process to try to answer those questions that are had. So we will then collect information and conduct assessments, and we have been doing kind of a hybrid model. So some things have been done virtually and some are done in person. And we also do rating scales. So there are different rating scales to collect information, and we will have, if it's a child or an adolescent, we'll have the individual as well as a parent, and typically also get input from their school and talk with their therapist. So we try to have a really comprehensive approach to collecting information so that we can get the best, overall picture of the individual, and not just using, a couple of assessments that were given over a few days in order to inform our diagnoses. And then after we've collected all of that information, we put together a comprehensive report, and then we have a feedback session where we go over any of those diagnoses as well as recommendations. So we try to provide a lot of recommendations to help to navigate, especially if there is a new diagnosis of ASD given, whether it's a child, adolescent, or adult, to help them to kind of navigate that and what they can do to seek out support from their family, community, school, and other avenues. So some of the things that we use to collect this information, so the ASRS is an autism spectrum rating scale, and the GARS, those are both rating scales that look at more of those DSM characteristics related to autism. So those can be given as a self-report, which would mean the individual that we're assessing is completing it, but it can also be given as a parent report or a teacher report. So we're getting those multiple different aspects of information. The SRS is a social responsiveness scale. So that's looking at more in depth at those social behaviors and social relationships and trying to determine if there are any deficits in that area. We also typically include a sensory profile to see if there are any of those sensory differences that we mentioned, as well as the ADOS and the MIGDAS. Those are both more structured clinical evaluation tools that we do in the office setting, and that gives us a lot of information and feedback based on the responses that the individual that we're assessing gives, and then also any observations that we have made during the evaluation.
So in regards to cognitive testing, so when we're doing an autism evaluation, we typically do cognitive testing, which can include IQ testing, but then we also typically do some executive functioning as well. So for research, in terms of like research, it's still kind of ongoing. And if there is like an ASD cognitive profile, which we would expect, so that would indicate strengths and weaknesses in certain areas. So there's not like a profile that we're looking for. If a child fits it, then they have autism. Although autism, you can have an average IQ with autism, or you can have an intellectual disability, or you can be gifted. So it's a quite the range there. But the cognitive testing is still useful. So it can tell us where the strengths and weaknesses lie. So especially like if we're looking at school accommodations or things like that, it's really important to know, is there a deficit in memory? Is there a deficit in processing speed? Are there ways we can help the child receive accommodations and supports, which is going to support the way their brain is functioning? We also do some executive functioning testing. So that can take a look at like, what's planning ability look like? Are they cognitively rigid, which could be if they learn rules for a certain task and then all of a sudden a task changes, are they able to keep going, or are they hung up by what they learned previously? So all of this can give some good information, which can really help us help the children practically. Because for example, if they are struggling with being rigid and struggling with being cognitively flexible, we can recommend something like when they learn new tasks in school, give them some extra time, give them some extra support, and help them be able to transition over to a new activity. So people often do get confused. So there are differences between a school evaluation and a clinical assessment. So at Courage to Connect, we're a private practice, we do a clinical assessment. So we use the DSM-5 diagnostic criteria, which we have been talking about throughout this presentation. For special education, they are not using the DSM-5 criteria. There are their own criteria, which are basically based on the DSM, but it's kind of like the check marks are in different places. And I've worked for a variety of districts, and there's no one paperwork across the state that shows that is the same in terms of the exact eligibility requirement. So it kind of varies. But what can happen? So sometimes parents can get confused, understandably. You can have an outside diagnosis of autism and not be eligible for special education in the school. To be eligible for special education in the school, there has to be an educational impact. So educational impact does not just include academics. It also includes social skills, peer relationships, executive functioning. So oftentimes that is affected in the school environment. I have seen, especially with girls, where it's not coming out at school, it's coming out more at home. And then in those cases, there hasn't been like an IEP or a 504 plan. And then a 504 plan is more for like accommodations and things like that. For an IEP, there has to be that educational impact, like I talked about, and then the child also might need, will also need direct instruction. So the direct instruction could be, and like reading, writing, math, if that's affected. It could also be social skills instruction, and it could also be executive functioning support as well. So that's kind of, the school has their own criteria. Their evaluation may look similar, like in terms of components, to a clinical evaluation, but they don't always line up. It won't always be the same assessments given in school as given in an outside private practice. So it's important, if a child is getting an outside assessment and a parent feels like there is school issues, it's important to coordinate with the school to make sure everybody's on the same page in terms of the evaluation. So I already hit on some of this, possible supports and services for children at school. Smaller class sizes can sometimes help. I mean, even to the point where children with autism may attend like a private day school with really small classes. I had experience working in a private day school that does serve primarily students with autism, and that can be very beneficial, I have seen. Also, things like just a simple thing like having a visual schedule for the day can be extremely helpful if somebody is struggling with being rigid in transactions. Those warnings for transitions, like a 2-minute warning, we're going to be going out to recess, you're going to have to clean up, that can be really helpful. And not necessarily a support, which would be listed on the IEP, but just building connections with staff is so important. Building connections like, so the child with autism feels like they can trust their teachers, trust the support staff, and then school functioning is just going to be so much better. And then in addition, things that can be added on to the IEP, occupational support for sensory differences. They can also help with like emotional regulation. And then speech therapy to help with any of those speech delays we were talking about earlier. So think like ways an evaluation can help. So a lot of times we see parents who are struggling, like, is this social anxiety? Is this autism? Like, what exactly is going on here? It can be really helpful to narrow that down, really define what the diagnosis is, especially if there's multiple diagnoses. We want to get a picture of what's going on so we can really help the child. And like I was talking about earlier, the outline of what the cognitive functioning and executive functioning can be really helpful in relating to your child, and then also helping them understand how to succeed in school. And then just in general, like we understand like getting diagnosed with autism and going through that process, it can be really tough, can be really painful for families. It can be a lot to process for sure. So we are very compassionate and stand by families in possibly receiving this diagnosis, which is huge. So we frame it like that, and we try to provide as much support as possible. And then we're all school psychologists in addition at Courage to Connect, and that makes us especially geared for giving those recommendations for an IEP, for giving those 504 recommendations, because we've worked in the schools and we have an idea of like what is going to work. So I have some slides too on autism for adults. I believe a lot of this could also be applied to adolescents as well. And so for adolescents and adults, as I've kind of hinted at, like we want to get at their personal experiences. We want to hear their perspectives. We want to hear what they're thinking. And there's a good quote by an autism researcher, like evaluation relies much more on getting under the surfaces, listening to the experiences they're having rather than how they present themselves to the world. And, you know, I've had clients when my first impression is like, I don't think this person could have autism. But then, you know, we have a long conversation. We talk about friendship histories. We talk about how they perceive themselves fitting it in. And it becomes more apparent that there is more going on there. And so, you know, some of the later diagnoses, whether it's in adolescence or adulthood, again, narrowing down like what is wrong so we can work on providing supports for that. Autism, like even in teenagers, likely to be diagnosed as depression, anxiety, personality disorder, and then you go down that trail of treating that. Well, in the meantime, the person is not being supported for their needs. So things like that might happen after a later diagnosis, like there is a lot of reprocessing that needs to go on, like thinking about when you were younger, thinking about when you struggled to make friends and having some answers as to why that might have happened. And it can be mixed with people. Sometimes people are really relieved and have people start crying when they receive the diagnosis, and it just makes so much sense. Other people, it's a little bit more difficult, but hopefully getting this diagnosis when it's accurate can move people more onto a path of accepting themselves. And then they also have more clinical language to explain those patterns of behavior. They can express themselves to people around them and be like, there is a reason why I'm like this. And then also, I think it's really important for autistic individuals to reach out to other people. And there's some hashtags. I'm not super big on social media, but there are some hashtags that can be used for people who are better with technology than I am to connect with others. But overall, it's just like trying to figure out your identity as an autistic person after you get this diagnosis. And it's a lot to work through. So for some older individuals who are able to engage in talk therapy, I think it's important to frame it like trying to understand how they work. Not necessarily, we don't want to tell them like how your brain functions is wrong, because it's not. It's like, this is just how they're wired. So it's important to relate to them, get to them on their level, support their needs, teach them how to communicate their needs as well is really important. And you don't have to change them and say like all of a sudden, if they have sensory difficulties, you're gonna train them to love crowds. That's their natural nation. You might have to come up with some supports, like if they do have to go into a crowded place, what they're going to do. But your goal doesn't have to be to change who they are at the core. And people may feel like they don't need as many friends as other people, and like that's okay. Not everybody has to be the same. But things that could be worked on in therapy, oftentimes attention's affected, alertness is affected, emotions can be affected too. You know, if you're being set off all the time because of difficulty with transitions, difficulty with change, sensory issues, giving coping strategies to help with all of those can be really helpful. Kim, did you want to start taking questions now, or do you want me to finish what I have?
I would say, do we have a lot of questions so far? Not sure.
Yeah, I'm not.
If Dana or Ryan can.
So there are 3 questions if you'd like me to read them, or.
Okay, if there's only 3, did you want to?
Yeah, I can keep going if there's only, yeah, I think I am, yeah, I do see I think there's 4, I think there's 4 questions.
Now, yep.
Okay. Yeah, I can go ahead. I'll just talk briefly about the concept of autistic burnout, which is like, it's still being under investigation in the literature, but it is something that is coming out more. I am seeing in assessments, like patients are referencing they've heard of it. And then also, you know, I've looked into it, and it really does seem to explain some of the phenomenon that happen. Either I've seen this in teenagers as well, like teenagers right out of high school, and it's just like the load of trying to fit in, like trying to deal with all the sensory input, you know, maybe being misunderstood by your family, misunderstood in school, like that just kind of builds up to the point where it becomes difficult to function. And it is hard to find treatment and to find help as an adolescent or an adult with autism. It is difficult to find like resources in the community and counselors who specialize in that. And this can have a real toll on people. It can negatively affect health. It can affect like their ability to live on their own, even to the point where it can lead to like suicidal behavior. So it's something very important to keep an eye out for. But other effects, let's see. Oh, there we go. Sorry, I skipped a slide. Some effects we see, it could be things like reduced executive functioning, trouble staying organizing, trouble just having that resiliency, bouncing back from daily tasks, It could be a lot of anxiety. What I've seen in a lot of later high school students and early college students is that trouble with life transitions, trouble starting college, trouble like moving on and establishing like their new identity. And there could also be, some exhaustion from trying to mask their autistic traits to fit into like a more neurotypical world. Other characteristics, I think I pretty much hit on those. Yeah, so it's just something like to be aware of. If you're a clinician, keep your eye out for it, because it looks like it is different from just being burned out from a job, just being burned out from depression. So try to figure out like how much has like the autism characteristics affected the person, and do we need to focus more on that in treatment? As opposed to just treating depression. Because if you're treating like this autistic burnout in clients, you may want to focus more on like teaching people to accept who they are, teaching them they don't have to camouflage their autistic traits, that they can function in the world the way that they are, and try to get the supports that they need without getting invalidated. So yeah, we've had some adults who have used our reports to try to get some job accommodations. I would say too, I didn't have a slide for this, but in regards to young adult college students trying to get accommodations for that as well, beneficial things that colleges are willing to grant can be like extended time on tests, which can be great if you get distracted, taking tests in a private room, a note taker. So that's something we're able to work out. Like if a recent high school graduate comes to us and they're getting ready to go off to college, we can take a look. Each college has their own requirements as to what sort of evidence they need to provide accommodation. So we're able to dive into that, really think about the person's functioning and make recommendations so the teenager can be successful in college. But other possible accommodations for adults, things like longer lunch break, reduced hours, extra support, maybe not having to go to mandatory social functions, step-by-step instruction. And it's going to vary what's helpful for each person. This should be individualized. For some people, they might prefer to work at home. But really just being concrete, providing examples, making expectations clear, I think are really helpful. And things like special software to help with writing can help adults be able to make better use of their verbal skills. So yeah, just keeping expectations really clear can help. And then, just like if you are a therapist, if you are working with children or adults, keep an eye out for if you suspect an autism diagnosis. Don't be afraid to make a referral. And there is a lot of social, like especially recently, more social media information coming out about autism. So sometimes people will watch and think they have autism, and like we do, like those resources are of differing quality, but we do want to pay attention. We don't want to invalidate immediately the concerns if somebody says, I think I have autism. We want to listen to them and see why they think that, instead of dismissing it because they just saw it on TikTok. And then there is one, this is a screener for adults. This one actually has some research on it, does not diagnose autism, but it can be more of a screening. And if you feel like somebody is presenting with those autism characteristics, you can have them take it in session and then look at the results together. So I think, oh goodness, looks like a lot of questions. So I'm looking at Stephanie's questions about the differences between female and male children. Yeah, I think it is the differences primarily are attributed to the different ways of socializing rather than a biological difference. I think like hitting on the fact that socialization, social connections tend to be more important than girls is kind of socialized with girls since an early age. Yeah, and it definitely can't be nuanced in how those show up. Okay, I'm looking at Stephanie's second question. So yes, It is hard for adults with autism to get a formal and thorough evaluation. Sometimes insurance can give us difficulties. And a lot of times, like what I kind of alluded to before, people, adults who suspect they have autism are oftentimes dismissed. They might read something on social media or have a friend that has autism, and they bring those concerns up to a professional and they can be dismissed. We are very validating at Courage to Connect. I really value the most hearing about adults' experiences, and I take it very seriously when somebody comes in and says they think they have autism. And we do a thorough diagnosis as well, take a thorough history. We're really careful and thoughtful about that. And I do think it can be hard to find a really good evaluation.
We do
Oh,
also, I was just
yeah,
going to, we do
go
also
ahead.
look at other aspects. So, you know,
Yes.
if there are concerns with like anxiety, ADHD, sometimes there can be some overlap between different diagnoses. So we do also look into other things that could potentially be causing these difficulties to make sure, again, like Dr. Long said, we're doing the most thorough evaluation.
Yeah, and we're looking, I see a couple questions about the correlation between ADHD and autism. There are overlaps. I think researchers are, like, some people believe they're kind of manifestations of the same disorder. I think researchers are still working that out, but typically when we do autism assessments, we are looking for ADHD as well. With ADHD, you can have social difficulties for sure, because let's say like somebody is talking to you and you're not listening, you may not be able to establish like those social connections. And sensory difficulties are also a part of ADHD, and people can have both ADHD and autism. So that's why we do the thorough evaluation and we try to sort those out. And so I'm looking at Jenny's question, can an LCSW diagnose ASD or must you have a PhD? That I don't think I can really answer. I would encourage you to look into your own licensure regulations. I've heard, like I've seen this debated like online and testing groups and never had like an answer, like a complete answer. And it also might vary across state. An LCSW may not be able to do some of the comprehensive assessments we do depending on their training. So like we do cognitive and neuropsych assessments, and an LCSW might not be able to do that. Although of course we recognize you can, you know, identify characteristics of autism. Okay, so I'm looking at David's question. And has been, yeah, so I would, sorry, the questions are moving around. Okay, hold on a second. Yeah, I would, so if you have a young adult that you feel like has been misdiagnosed, and has been told they do not have autism, but it looks like they have autism characteristics, you could gently bring up some of the things that you feel like may reflect autism. And then also just acknowledge, like, sometimes like the schools are invalidating, or other professionals can be invalidated, and encourage them that they can find a professional who will take their issues seriously and do that differential diagnosis to figure out, you know, is it a mood disorder? Is it a mood disorder and autism? What's going on there? Okay, 15-year-old. The less typical are other ways of thinking. Well, they don't. So I'm looking at the other David's answer. They don't necessarily. So there's the 4 criteria for the repetitive issues. They only need 2 of those to keep in mind. So you don't need to see everything. Some of the less often sort of signs of repetition, I'm thinking of those restricted interests can be different. Like you can dive into those because sometimes it might seem like a typical interest, but look at the level of intensity. So don't just look at whether it's kind of an odd stereotypical interest, but look at it like how intense is this interest is one way to think about it. If you're looking at some of the motor, repetitive motor movements, pacing can be one, twirling can be one, sometimes picking is missed. I think people just typically think of hand flapping, and some of those other issues are missed. And sorry, Kim, feel free to jump
No,
in.
you're fine. I was actually just typing in a couple answers
Oh,
to
thank
answer some of
you.
the other questions.
Okay, so what kinds of questions would someone doing an evaluation ask a therapist? So yeah, I think the best thing we could do, like when we're doing an evaluation and when we want to coordinate with therapists, is share your impressions of the client. Like, we really value your work as somebody who knows the client, as somebody that works with the client, and we want to know your impressions. And in terms of how you can encourage the client, let them know, like, support them. Like, it can be a difficult process for sure. So just give them encouragement. Like, there's a lot of paperwork to fill out. There's a lot of questionnaires. They're asked a lot of questions. Like, encourage them to go through that process. Encourage them, like, sometimes it's hard answering those questionnaires. Sometimes you kind of see yourself in a different light, and that can be hard. So just acknowledging, like, an evaluation can be difficult, and like, support, like, trying to build them up, let them know, like, they're going to get good results out of this. They're going to learn a lot of information, but yeah, it can be painful. Acknowledging that.
And I don't know if you already touched on this, Jamie, because I was answering questions, but when we call and talk with a therapist for individuals we're doing the evaluations with, we like ask more directed questions if
Yes.
we have specific information we're seeking, so that you guys can help us with the evaluation process. And we value the input of the therapists and clinicians that work with the individuals that we test.
Yes. So Kim may have her own view. I know there's been more controversy coming out about ABA not being an effective intervention for children. Like, I think it's going to depend on the family. I do think, like, my overall philosophy is, like, we should accept people with autism how they are, and not necessarily teach them to hide and mask their characteristics, because that is associated with anxiety and depression. So I think it does have to be done carefully. I would like to see, like, the outside world also change and accommodate to help the person with autism, instead of us viewing it like the person with autism has to change themselves to fit in. I think we should be more inclusive and accepting of people's differences. No more questions.
All right.
All right, guys. Well, thank you so much. It was a very informative and interesting webinar. So thank you again for taking the time.
Thank you.
You're welcome.
Yeah.
Thank you for the opportunity.
Thank you so much for hosting us.
All right, everyone, enjoy your Wednesday.
Bye-bye.
Bye.